Welcome to Grand Rounds this week. I'm very excited about our talk today. Dr. Stan Sonu is an assistant professor of internal medicine and pediatrics at Emory. I met him just over 2 years ago when he was selected to be associate program director for the Emory internal medicine residency program, and has been fantastic in that position. He obtained his medical degree at the Medical College of Georgia and then went to Chicago to do his residency in combined internal medicine pediatrics at Rush University Medical Center. He was also chief resident in pediatrics there. He followed that by doing a fellowship at the Cook County Preventive Medicine and Public Health Program. And at that time, he also got an MPH at Northwestern University. His research interests include addressing and preventing adverse childhood experiences and integration of trauma-informed care in clinical practice, which is an area that is, I think, growing in recognition, has clearly always been important, but something that has come onto our radar screen as something as internists we need to really understand and focus our clinics to address in a better, or to incorporate in a better way. Stan has been a phenomenal mentor to our medical students as well, who all come to me with enthusiasm after having talked to Stan about many of these interests. So Dr. Sonu, I'm thrilled to introduce you today, and I can't wait to hear your talk, The Elephant in the Exam Room, Understanding the Role of Psychosocial Trauma in Clinical Encounters and How Internists Can Respond. So I'll turn it over to you.
Thank you so much, Dr. Armstrong. Please let me know if you can't see my slides here. Okay, so thank you again, Dr. Armstrong, for that very warm introduction. Good afternoon, everybody. It's an honor to share with you today on a topic that I firmly believe is nothing short of fundamental to delivering patient-centered, empathetic care, and what some people have referred to as the hidden pandemic. But this topic of understanding the long-term effects of trauma, it isn't something that I learned about in medical school or most of residency. I'd be willing to bet that a good chunk of this audience here similarly did not hear about this during their training. I was actually only 3 months away from graduating residency when I first heard about this topic, and I have to say I was stunned. My jaw was just on the floor for so many reasons, which we'll unpack in the next 45 minutes. But one thing that really stuck out to me and represents the initial elephant in the room that got me into this topic is how we can so easily misunderstand a patient or a family member because we lack narrative context. And so let me share a personal story that illustrates this point. A couple years ago, when my wife was pregnant at the time with our second child, and she went into labor, we checked into a local hospital around 7 p.m. and within a couple hours, even though it was a really busy night in L&D, she received an epidural and was reasonably comfortable. And after 4 or 5 hours of rest, the epidural started to wear off and my wife asked to be redosed. So I pushed the call button like a good husband and asked if somebody could come by with more medication. An hour goes by, no one comes. I ask again, this time in person, and I'm told, yeah, if someone's coming, please be patient. And I should note that they did not know that I was a physician. Another hour goes by, and at this time, my wife is now in excruciating pain to a level like I've never seen before, and I'm very alarmed at this point. So I ask a third time if anyone is coming again, and was reassured that, yes, you're next on the list. Sorry, we're so busy, but we're on the way. Now, in the midst of trying to get comfortable, my wife took off a blood pressure cuff that was placed next to her IV. And I had just set it next to her bed, and she wasn't hypotensive or hypertensive or anything like that. I was keeping an eye on things, and I just set it next to her bed. And about 5 minutes later, someone from the anesthesia team finally comes in. And the first thing this person says is, as my wife is crying in pain, the first thing this person says is, "What is that blood pressure cuff doing on the bed? It needs to be on her arm at all times." And in that moment, it was sometime between 4 and 5 a.m., I lost it. I was so angry. And apparently when I get really angry, I get very sarcastic. And so I said, are you seriously talking about this blood pressure cuff right now? Is this really the first thing you want to say when my wife has been waiting in agony for 3 hours? And this person actually shouts back at me. And for the next 30 seconds, we go back and forth. We're snapping back and forth at each other while my wife is still laying there in pain. And eventually things kind of calm down. He leaves the room, he brings back medication, he redoses her epidural. In a few minutes, she starts feeling better. And that makes me feel better. And eventually I'm calm enough and I turn to him and I say, wow, I'm really sorry for losing it there. And he apologizes back to me. And a few hours later, our daughter is born without any complications. I share this story because I would never want to be identified or defined or be known by a moment of anger or frustration or exasperation, especially in the context of a very stressful situation. No one does, right? And yet, in the rapid pace of our health system, oftentimes a lot of patients and family members are labeled for, quote, challenging behavior. And to me, I think this is one of the biggest elephants in the room. Because whether it's an FYI flag in the chart that states that this person is a seeker of pain medicines, or a note stating how this patient was rude to a doctor or a nurse 8 years ago, instead of understanding the context out of which an undesired behavior occurs, or even giving the benefit of the doubt, we're human. We have a tendency to take mental shortcuts and we automatically attribute that behavior, that problematic behavior, to the person's character. And so that's what this talk is going to address today. You know, it's really about the scientific rationale for empathy and how this science can be another frame or another tool by which we can maintain and hold a perspective of compassion and view our patients holistically, which ultimately will strengthen the relationship that we have with our patients. So what I'd like to do in the next 45 minutes or so is to use this theme of an elephant in the room to highlight some of the ways that trauma can manifest in clinical encounters. And then after that, pivot to some of the things that we can do in response with a compassionate and empathetic approach. So what's our first elephant? Well, the first elephant I want to call our attention to is this link between psychosocial trauma and undesired health outcomes. This might be something that a lot of us didn't even realize was an elephant in the room, but it is. We intuitively know on some level, right, that the most common conditions we treat and diagnose in internal medicine, things like high blood pressure, diabetes, heart failure, stroke, we know that a lot of these things didn't just develop yesterday or the week before, but we really don't have a great way of integrating narrative context into our care, and I think we should. Why? Well, I want to start off by sharing a story that I always share whenever I give this talk. And the reason I share it is because it always sets the stage for me of why this is such a paradigm shift in our thinking. So if you come back with me to the mid-1980s, we're in San Diego, California, and at the time there was a physician named Vince Felitti who was the medical director of a weight loss program or a weight loss clinic out of Kaiser Permanente in San Diego. And the thing about this clinic, this program, was that it was actually very successful. It's pretty aggressive, but it was very successful. Men and women would come in, they would lose weight, and they would keep it off as long as they stayed in the program. And what Dr. Felitti noticed over a period of 5 years, though, was despite the program's success, about half the participants in the program left. What confounded him even more was that most of the people who left the program were either losing weight or at their goal weight when they left. So why would people be leaving a program if it was doing exactly what it was designed and intended to do? And so, being the very curious person that he is, he sought to interview as many of these ex-participants as he could, and he got to about 285 people. But really, it was through one woman's story that he kind of serendipitously stumbled upon an unexpected phenomenon. The story goes that while in the program, this woman went from being over 400 pounds down to 130. When she got to 130, she disappears. And several weeks later, she comes back having regained almost 40 pounds. And when Dr. Felitti interviewed her, she shared that a coworker, an older gentleman, after she had gotten to about 130, this one day at work, an older gentleman hit on her. He made a sexual proposition to her. this unexpected solicitation in turn, triggered these deeply buried memories for this woman of when she was sexually abused during childhood by her own grandfather. It was during this period of abuse, it turns out, when she was a child, that she began this habit or pattern of binge eating. And what she noticed almost on a subconscious level was that as she gained weight, she became less and less noticed by her grandfather. And so as she got older, she subconsciously generalized this strategy to other potential predators in her life. And so for this woman, eating and gaining weight was her way of protecting herself and going undetected from other potential predators. Dr. Felitti had never heard anybody talk about a health risk behavior like unhealthy eating or not watching what you're eating described in this way. So he went back to his team and he said, hey, we need to ask everybody about what their lives were like in childhood, because it could still be at play in terms of their decision to stay in this program or not today. And so what they found in this small case control study, again, of about 300 people, was that most of the participants who had left the program had some experience of abuse in their childhood. And sexual abuse was particularly common. It was unexpectedly common in this study. So the key lesson for Dr. Felitti and his team, the aha moment that they got from the study, or the thing that allowed them to see the forest for the trees, was that what they perceived to be the problem in their patients, in this case, obesity, was in fact, for a lot of the ex-participants, their solution to a different problem, one that happened decades earlier. In a way, their solution was a defense mechanism. It was an adaptive survival skill, but one, of course, that had serious health consequences. And from this small scale study, this is what inspired and led to the creation or development of the Adverse Childhood Experiences Study series, which ran for about 10 years. And so a lot of what we know about trauma is derived from this landmark study. It's been cited over 12,000 times and continues to be cited to this day. And people are often surprised to learn that this study was published not in the 2000s, but in 1998, well over 20 years ago. And I wouldn't be surprised if half our audience here hadn't even heard of this study before. But this is considered in the public health world a monumental effort. It was a joint effort by the CDC and Kaiser Permanente in San Diego. And what these researchers did was they surveyed over 17,000 adults on their history of 10 different categories of adverse childhood events or adverse childhood experiences, or what we call ACEs for short. Now, these ACEs spanned 3 domains across abuse, neglect, and household stress, included questions asking about physical, emotional, or sexual abuse, physical or emotional neglect. And then they asked about 5 different types of stressors that a person could grow up with or experience in the home. Things like mental health problems or substance use disorders in a family member, an incarcerated relative, intimate partner violence against the mother, and then lastly, parental separation and divorce. And I want to summarize some of their key findings in this next section here. So the first key finding from the ACE study series, and one that really was stunning when they thought about it, was trauma is common. ACEs are common, a lot more common than perhaps we might think to ourselves. Well, how common were ACEs? How common were ACEs in this study? Well, when they quantified the number of ACEs each person had, what they realized right away was almost 2 out of every 3rd person had 1 ACE or more. About 1 in 8 or 12.5% had 4 ACEs or more, an exceedingly high burden of trauma. On the flip side, you can see that only about 1/3 of people had a childhood that was free of any of these events. The second key finding from the ACE study series, and this is what had my jaw on the ground that I had to pick back up, was this relationship. They saw a robust dose-dependent relationship between the number of ACEs people had and their risk for a wide array of adverse health outcomes. So in broad strokes, what they saw was that the higher number of ACEs a person had, the higher risk that person would be for some of the most common health and behavioral problems that we see all the time in internal medicine. Things like health risk behaviors like tobacco use, heavy drinking, illicit substance use, mental health problems like depression, anxiety, a history of suicidality, PTSD, Chronic disease. So we're talking about events that happen in childhood can actually show up in some way decades later in the form of chronic disease. And so we're talking about things like ischemic heart disease, stroke, COPD, non-skin types of cancer, even diabetes. Then they found this association between ACEs and more socially facing or socially important outcomes, like the ability to hold down a job or maintain financial stability. And then all throughout the school years, we can certainly see the effects of ACEs play out, especially in academic failure and delinquency. Just to give you an idea of what this dose-response relationship looks like, here's a slide that looks at different mental health outcomes that were studied in the ACE study. And this bar graph shows the y-axis is prevalence, not risk, of some of these mental health outcomes with the corresponding ACE score in the bar graph there. So what you can appreciate is that there's a stepwise gradient of the prevalence of these outcomes according to the ACE score. Bottom line, the higher the ACE score, the higher number of ACEs a person had, the more prevalent these conditions would be. This is an example of ACEs and impaired work performance, so some of the financial consequences of ACEs. And you can see, again, there's a sort of consistent staircase pattern. The higher the exposure, in this case ACEs, the higher the prevalence of the outcome of interest. Now, in terms of risk of specific outcomes associated with ACEs, we know that there's a wide range of important observations to note. For people with 4 ACEs or more, if you compare them to other individuals with no ACEs, and after you adjust for age, sex, gender, race, ethnicity, even educational attainment, the risk of some of these health risk behaviors is substantial. So a history of a suicide attempt, 12 times greater for individuals with 4 ACEs or more. IV drug use, alcohol use disorder, between 7 to 10 times greater, and so on and so forth. For chronic diseases, some of the most common things that we see and treat in internal medicine, the risk is high as well. So again, comparing people with 4 ACEs or more to those with no ACEs, after you adjust for sociodemographics, the risk of COPD is almost 4 times greater. For stroke and heart disease, over 2 times greater. Any cancer or diabetes, between 1.5 to 2 times greater. And this isn't the only study that has shown this association. Several studies that have kind of looked at the same question in different ways have found generally the same thing, that ACEs there is this sort of connection, even after you adjust for typical risk factors related to these diseases, even after you account for them, there still is a signal where there's something about ACEs where it can disrupt our physiology, promote cascades of chronic inflammation, and show up in the form of chronic disease decades later. So the final key finding that I want to highlight from the ACE study series really follows from the logic of the first two. So if 1, ACEs are common, and 2, there's this relationship with a multitude of adverse health outcomes, at some point we should expect to see an impact on mortality or lifespan. And so for me, this is always the most stunning finding of the ACE study. When these researchers followed the participants forward for about 10 years and they kept track of death certificates, what they observed was that for people who had no ACEs, the average lifespan was about 80 years. But for those who had 6 or more, the average lifespan went from 80 to 60, a difference of 20 years, and the measurable difference between these two groups being the burden of trauma that was experienced before the age of 18. Now, the original ACE study only included 10 categories of adversity, or 10 categories of trauma, and they all occurred in the home. And most of them were interpersonal or relational. But we also have to acknowledge that there are many other forms of trauma that are disproportionately experienced by communities across our country and the world. And so to illustrate this point, I like to use this figure which we call the tree of ACEs. So if you imagine with me here, the leaves and the branches of this tree represent the conventional or interpersonal ACEs in the home: abuse, neglect, household stress. We've already talked about it. As a tree is growing, it grows from this foundation of roots, or a network of roots that provide the foundation for the tree. And we refer to the roots here as adverse community environments. These are things like violence in the community, poverty, racism, discrimination, housing instability, economic disadvantage in the community overall. In and of themselves, each of these are independently associated with adverse health outcomes. But as they relate to ACEs, they're thought to provide this kind of contextual hotspot out of which the leaves and the branches, the interpersonal ACEs, might occur at higher frequency, higher severity, or I think most commonly in the absence of a mitigating resource. Turns out that poverty is like pouring gasoline on the fire of ACEs. And the clearest example that I come across almost weekly in the clinic, whether I'm in internal medicine or in peds, is mental health resources for people who are underinsured. Our mental health our landscape across Atlanta and really the state of Georgia is quite far behind other states. So we could do a lot better in this point. But I just bring that up to illustrate this connection of if you have someone who's experiencing ACEs, but they live in a community where there's not a lot of resources where they can have those ACEs addressed or the consequences of ACEs addressed, that puts that person at a significant disadvantage. Now, this illustration doesn't stop here. It goes one step further. So as a tree is growing, the roots are drawing in minerals and nutrients from the surrounding soil. And so in a lot of ways, what's in the soil is predictive of that tree's future trajectory. And so we refer to the soil, and a lot of this is derived from what we've learned through epigenetics in the past couple decades. We call the soil adverse collective historical events. These are events that, and I put examples in recent history, that have clearly conferred an intergenerational impact. Things like slavery, Jim Crow, mass incarceration, the Holocaust, forced displacement of Native Americans, genocide in Syria and abroad, otherwise. COVID, especially from last year, COVID definitely will have ramifications that we will see and feel for generations to come. And so if we take a step back and just think about what we've covered, all of the data that we've looked at until this point, ACEs and all these health outcomes, I hope what becomes clear is that this experience of trauma or adversity in childhood for a lot of people is not just an experience or just a part of someone's past. On the contrary, the experience of trauma can actually be devastating across multiple domains of well-being and functioning in society. Now, at this point, like any good internal medicine doc, you might be thinking, okay, all this trauma has already happened, Stan. Why do I need to know this? What do I do with this information? And I would say that's a fair question. And I would argue that knowing this association still has substantial implications on our practice. And so let's move on to the next elephant to learn more and describe more about this. So continuing on with the theme of the talk, the next elephant in the room is unpacking this dynamic between psychosocial trauma and behavior. And I think this might be even more salient to our day-to-day practice. To give some perspective or framing for this section, what's important to understand here is that in children, the most common way that ACEs show up, the most common manifestation of ACEs is actually in behavioral problems and maladaptive coping tendencies. Here's a list of some of the most common outcomes related to ACEs in children. And what you'll notice is that most of them are related to some type of behavior. So it's no surprise that the top two most common outcomes that we see are 1, academic failure, and 2, delinquency. And just because a teenager turns 18 or ages out of pediatrics, it would be a mistake to think that these behavioral problems would suddenly disappear or just resolve spontaneously. So what we're really asking with this relationship between ACEs and behavior, we have to answer this question: how is this happening? What is driving this relationship between ACEs and all these health outcomes? Well, in the past 3 decades, with the advent of more sophisticated brain imaging technology, there's been this incredible, remarkable convergence of research from so many different fields: child development, neuroscience, psychology, sociology, medicine, public health. And what all of these fields have been orbiting around is really understanding how stress and trauma affect our brains. You see, we've known for a long time that healthy brain development is fundamentally experience dependent. So in the first 2 to 3 years of life, there is a dramatic proliferation of the neuronal network within the brain, followed by a period of pruning. And neurons that fire together will wire together, whereas on the flip side, neurons that do not fire together, perhaps as a result of not having that experience-dependent input, but neurons that do not fire together will not wire together as readily. And we know this to be occurring based on studies, older studies evaluating early child developmental outcomes. So the figure on the right here is from an older, also landmark study that was done in the 90s, which is why it has welfare as a label. And what it shows is a different number of words children knew according to their parents' socioeconomic status. And so what we can appreciate here is that by 3 years of life, there are marked differences in the number of words children know. And even as early as 18 months, we can start to see these disparities emerge. And so what's happening here? Well, the hint is it's not that children whose parents were on welfare were loved any less. That's couldn't be farther from the truth. The answer here, I believe, is the adverse community environment of poverty. And so what does poverty do to delay or disrupt language development? Well, conceptually, what we know what's happening here is that ACEs and adverse community environments can provoke, like poverty, for example, can provoke a severe stress response phenomenon, which we call toxic stress. Toxic stress is separate from our usual kind of day-to-day stresses. It's not a bad day. Toxic stress, by definition, is a stressor that is severe, unpredictable, unrelenting, and without the presence of relational buffers that can help a person overcome those stressors. Another way to think about toxic stress is it's kind of like a hijacked stress response system. And if this is experienced during childhood, which is a very sensitive period of growth and development, toxic stress can actually disrupt brain development or neurodevelopment. And we're going to talk about this more in a second. The other major consequence of toxic stress, though, is that it actually stimulates dysregulated activity within the amygdala. The amygdala is the part of our brain that functions as kind of the headquarters, right, for managing these various inputs of stress. And among many roles, it activates the sympathetic nervous system, it regulates the HPA axis. So the net effect of toxic stress is persistent dysregulation of our neuroendocrine immune circuitry, which eventually promotes release of inflammatory mediators and cytokines, and eventually promotes chronic inflammation, which we know is a precursor of chronic disease. I want to talk for a second about one, I think, fascinating study that was published a couple years ago out of Boston. It was published in Lancet, that really highlights this relationship between stress, the amygdala, and disease. And so what this group here did was they took about 300 patients and had them undergo whole body PET CT, and they used the radiolabeled tracer whose uptake is increased with glycolysis. And they used validated methods to assess the actual activity of the amygdala. And so here on the top left here is a person with low amygdala activity. On the right is a person with high amygdala activity. And it's hard to see on this slide, but if you look closely in the paper, you can see the difference. And what they found was that higher amygdala activity predicted cardiovascular events like MI, stroke, arrhythmias. And this process, this connection between the amygdala, high amygdala activity, and cardiovascular events was mediated by two other signals of inflammation: increased hematopoiesis in the bone marrow, here within the spinal column, and evidence of arterial inflammation within the aorta. And so the mechanism they propose, I would say compellingly, is that in response to chronic stress, the amygdala initiates this cascade of pro-inflammatory mediators, which in the short term can help a person survive a threat, but in the long term has certainly some detrimental consequences, in this case, cardiovascular disease. In the same study, when they assessed the risk of a cardiovascular event from high amygdala activity, even after they adjusted for common covariates of cardiovascular disease, things like age and sex, the Framingham risk score, pre-existing atherosclerotic disease, combined cardiovascular risk factors, the association held. And what I'll say here is that the common cardiovascular disease risk factors include things like age, tobacco use, high blood pressure, diabetes, dyslipidemia, even a family history of cardiovascular disease. So there's some independent signal that the amygdala confers in the pathophysiology of cardiovascular disease that we might not be addressing as well as we could be, and certainly more to come in the future. Now, one thing I want to highlight is how the effect of chronic stress on the brain can influence regions of the brain that mediate behavior, regions of the brain that are really important for navigating the world. Now, I'm sharing this in a very simplistic, non-comprehensive way, but the idea is that as toxic stress promotes overactivity of the amygdala, it stimulates release of catecholamines that in turn actually inhibit the activity of the prefrontal cortex. The prefrontal cortex is it's the most complex part of our brains. It's also responsible for regulating self-control, planning for the future, displaying empathy, reasoning, controlling impulsive behavior, even accessing things like working memory. So the bottom line here is that when the amygdala is activated, so in the person's in survival mode, the prefrontal cortex is not in control. It's offline. They're not in learning mode when they're in survival mode. And this, of course, has real life implications on behavior. In the clinical context, well, what might we see? Well, first, I think we have to remember that perhaps despite our best intentions, many patients don't find hospitals or clinics to be places of healing. In fact, it's not unusual at all for a patient to feel that the clinic or a hospital is a dangerous place to be. And so I think it's important to realize that just the very fact of having to be at a hospital can put a person on edge. And so what I want to do is kind of walk through three of the most common behavioral outputs that we see, but this is certainly not an exhaustive list. The first one I want to highlight is hypervigilance, hyperarousal. This is a heightened sense of a perceived threat or danger, can show up as an intense affect, can show up as an anxious affect, excessive worry that seems out of proportion to the issue at hand. Hypervigilance can make pain management really challenging if the patient perceives that any change to the regimen is going to result in a bad outcome. We can also see emotional dysregulation. This is the inability to regulate your affect under stressful conditions, even mild stressors. And I would say the story I shared at the beginning of this talk, when I lost it at the poor anesthesia tech who was so busy, when I lost my temper, that was because I was emotionally dysregulated. This can be occurring in the patient who is yelling in the hallway because they've been waiting on their doctor for a long time, or true story, this could be occurring in the patient who refuses transport to dialysis because they didn't get a specific type of food on their meal tray. And we can look at that and say, wow, that's so silly that they would care about that. But if we kind of zoomed into their brains and saw what was happening, we would see that, you know what, they were actually in this kind of survival mode. They weren't using sort of the rational part of their brain. The third behavioral output that we see very often is avoidance. And this is avoidance of thoughts and memories and sensations, even conversations that remind us of past adverse experiences. This is a very common maladaptive coping strategy that often leads to substance use disorders. And I gotta say, I have yet to meet a person with severe alcohol use disorder who wasn't trying to run from pain. So those are the first two elephants. Let me just recap. Elephant one was the association between ACEs and health outcomes. The second one that we just covered was this relationship between ACEs or trauma and behavior. And the third elephant that I feel is really important to discuss as well, it's about the relationship between trauma and ourselves. And so what we'll do next is talk about how trauma shows up in our day-to-day. And what I've done is actually combine this part of the talk with the final section, since it just kind of naturally flows in that direction. So what we can do. Well, let me go back a second to the original ACE study that I discussed earlier. As it turns out, in these 17,000 adults who were recruited to participate in this study, they were not a group that the media or any other body would consider at risk for childhood trauma. These 17,000 adults were mostly white, they were mostly college educated, and all were insured because they were all recruited through the Kaiser network. So just based on sheer sociodemographics, this sample more closely resembles this audience on this call, perhaps more than our own patients. And so one thing we have to recognize right away is we cannot create distance from the findings of the ACE study in our own lives. ACEs are a lot more common and certainly have implications on our health and behavior, perhaps more than we give it credit for. We would be remiss not to draw the same connection between ACEs and our own health and behavioral tendencies. So especially this year with COVID. And some things that we have to be aware and really be attuned to is secondary trauma, the negative changes over time as we witness directly the suffering of our patients and the isolation that they have to endure. This can certainly affect our own well-being, our own mental health, and certainly is related to another phenomenon called moral distress. We have ACEs too. I hope I made that point. And the third thing is to understand that our trauma can actually show up in interactions with patients when we're hungry, when we're tired, when we're fatigued. Those higher level cognitive processes are much harder to execute well. And so what kinds of behaviors show up when our threshold is lower and we're stressed and hungry and fatigued? The same ones that show up in our patients: hypervigilance, emotional dysregulation, and avoidance. Here's the thing though, we know very well that not everybody who's experienced trauma in their youth is going to be doomed to these consequences. We all know people in our lives, it might even be you on this call, who have made it despite the odds. So what is it about you or people you know who are able to be successful and bounce back compared to those who aren't able to do the same despite having high numbers of ACEs? Well, there are many important concepts, but I think one of the most important ones to illustrate and to talk about is this idea of resilience. This is defined among people who are in this space as the ability to adapt and succeed in the face of adversity. When someone bounces back after a stressful event, or when someone can bend but not break, as the photo shows. There are two things we have to remember and know about resilience. And the first one is that there's not a single person born in this world who's resilient, who's born resilient. That doesn't happen. Resilience is built through the type and the quality and the number of positive adult relationship that a child has, their social ecology. But for adults, resilience can also be strengthened and reinforced in adulthood as well. The second thing that we have to remember about resilience is that if it's present, if it's actualized, that means that even in the face of future ACEs or trauma or a recrudescence of a painful memory in the past, that individual can still find ways to adapt and bounce back and succeed. So what are the critical factors necessary for cultivating resilience? Well, the first one, and this is what we call the game changer, is simply the irreplaceable nature of healthy, safe relationships. The reason is so much of trauma is represented by failed or broken relationships. And the way that we promote resilience and also heal from trauma is actually through safe, stable, nurturing relationships. This is a game changer in children, but it's also very critical among adults as well. Whereas adversity makes us vulnerable, relationships protect us. The second critical factor is to cultivate practices and rhythms and routines that can foster self-regulation. And what these activities do on a neuroscience level is just kind of settle the activity of the amygdala, which allows the prefrontal cortex to open up. It's kind of coaching the brain to realize, hey, that threat that you initially thought was there, it actually is not going to hurt you. You have power over that threat. And we already do self-regulation in society in so many ways, prayer, exercise, yoga, deep breathing, journaling, creating art. But there are also other deliberate and intentional ways to cultivate these skills, such as mindfulness, which I think we still underutilize to a large extent. The bottom line here is that resilience is important because it can convert or revert what could become toxic stress into tolerable stress. And because of that, ACEs are a risk for negative health outcomes, far from a guarantee. So then how should this inform the way that we interact with our patients, right? If trauma has such an impact in the lives of the people that we take care of every day, but we don't know who has or who doesn't have an experience of trauma, what should our approach be? And this is where this term trauma-informed care really makes sense to me. Because when we're talking about care that is trauma-informed, it's not a checklist of to-dos, it's a framework. And it's a framework that's grounded in understanding what trauma is, how it affects us, and what we can do in response to it. And the first sort of critical mental pivot is with trauma-informed care. So the fundamental sort of paradigm shift is when we are interacting with a patient or a friend, a family member, or a colleague exhibiting behavior that we might call problematic or self-destructive, and the knee-jerk impulse in us wants to say, what is wrong with you? Like, why can't you just stop? Like, why can't you just get it? Sometimes we don't even say that, right? Oftentimes we're a lot more subtle with it, and it might, the what's wrong with you message might come across in the brevity of an encounter or the line of questioning or the tone of questioning that we take, right? But what trauma-informed care is asking us to do is when we see that sort of behavior that's self-destructive, instead of thinking what's wrong with you, we pause, we step back, and we ask instead, or our approach instead is what's happened. And I'm not saying that we need to ask what's happened to you, but our approach, our sort of disposition, our posture is what's happened. And this is a logic chain, right? If trauma is common, if it's associated with all of these mental and physical and social health problems, if what we might perceive to be the problem actually represents that person's solution or survival skill, as maladaptive as it might be, then saying what's wrong with you is just the wrong question to ask, and it could further marginalize a person who never asked for that trauma in their lives in the first place. There are 4 things that trauma-informed clinicians and organizations and really trauma-informed policies do. And I think about this all the time, so I think it hopefully might be useful for you as well. The first R is to realize. This is simply realizing the widespread impact of trauma, understanding paths of recovery. That's what we're doing in this talk here. The second R is to recognize the signs and symptoms of trauma when they're apparent in front of you. Let me expound on this a little bit, because this is actually really, really, really hard to do. The intent here is not to assume or make judgments about your patients. That's actually the opposite of trauma-informed care. But if we see behavior in a patient that signals that they're in that survival mode, the amygdala is activated, they're in that fight or flight or freeze mode, what Recognize is asking us to do is to manage our own reaction. I don't know about you, but anytime I'm on the highway and I see some car be rude to me, cut me off, or kind of fly by me on the right side, for some reason I take that personally, and I think to myself, like, why is that person the worst person in the world right now? But it's not personal. And so I think recognizing is actually a very tough skill to develop, but it's certainly worth striving for. But you can't recognize until you realize how trauma shows up in our lives. After recognizing, after sort of identifying that trauma might be apparent, the next step is to respond. And this is not just talking about being empathetic or compassionate, but this is really looking to have a low threshold to referring to additional services as needed. And so I think we still, despite not having the most robust landscape of mental health resources, it's still underutilized to an extent. And so I think here is when we can sort of be more attuned to referring people as needed. And the fourth R is simply avoiding re-traumatization as much as we can. Again, like I mentioned before, these sort of healing environments that we work in paradoxically can be the opposite for our patients. And one thing that I share with our learners frequently on the wards is that, when a person requires admission to a hospital, inherently they're just not at their best, meaning their threshold for tolerating stress is lower. And so if there are things that we can do as a team to make that person's experience more, even slightly more conducive to healing, let's do it. So this means doing things like limiting overnight vitals for stable patients so they can get a full night of rest, ordering labs earlier in the evening so that patients don't have to be woken up by a phlebotomist at midnight for it. So these are just some basic considerations that I think we'd want someone to think for us, bottom line. I do want to walk through a case with the time I have left, so I'll try to be quick using these 4 R's. So the case is the overnight team admits a 65-year-old man with severe COPD, cocaine use disorder, HFrEF, he's got an EF of 15%, and he's admitted for a heart failure exacerbation. We're rounding on a different patient who was also admitted overnight when we received the following page. And if you can't see it, I'll read it out loud. It says, this is from a nurse. This patient is being unruly, demanding to leave, coming out to the hallway, coughing on other people, refusing to wear a mask. Charge is asking that he be discharged. So think to yourself for a moment, what initial knee-jerk thoughts come to mind about this patient? How excited are you to go to bedside at this point? So upon arriving to the patient's room, you find him undressed to his undergarments. He's pacing back and forth. He's visibly upset. He's short of breath. You barely have time to introduce yourself when he starts talking. He's speaking and shouting about multiple frustrations. He speaks uninterrupted for a few minutes, and he progressively appears more fatigued as he continues. Outside the room, the nurse asks one of your team members, he seems fine. He's just causing problems here. Can he just leave? And so let's work through this case using the 4 R's of trauma-informed care we just discussed. So realize, we go into the room, we know that any patient we see might have a history of trauma that manifests in behavioral challenges, especially under conditions of stress. Recognize, we don't take his frustration and agitation personally. We recognize that his brain is in survival mode, meaning because of some inciting trigger, his brain is acting like there's a grizzly bear in the room. He feels threatened and his rational brain is offline. Respond. So we conduct the encounter prioritizing a sense of safety. We use language that communicates a desire to earn his trust, not assume it's there. We sit down, we might listen patiently. We don't try to argue by rationalizing what we want him to do. And during this part, what we learned was that he really wanted to use the bathroom to have a bowel movement and take a shower. He did not want to do his business on a bedside commode. The patient was homeless, and to him, there was nothing more important than his dignity, and taking care of his personal hygiene was a way for him to preserve that. So he had actually stripped down, and this is kind of sad, he stripped down to show that he wasn't trying to get into the bathroom to use drugs. Avoiding re-traumatization. So we do our best to meet him where he is. After we do a brief exam, we say, okay, it's probably okay for you to use the bathroom with supervision. Why don't you wipe down with a washcloth instead of showering for now? So he returns to the room. He was much more amenable to receiving care and his medications for his heart failure. He actually becomes increasingly engaged with his care. He even expressed a desire to quit cocaine, but overnight, he leaves AMA because of another disagreement with another staff member. And this case doesn't have a happy ending. And I intentionally picked an example that doesn't, because the bottom line is the way we interact with patients should not be dependent on some outcome that we hope for. Again, trauma-informed care is not a specific intervention. It's a framework for delivering care so that whatever the context or situation, we are treating our patients with dignity, understanding, and respect. There are a number of guiding principles for trauma-informed care. I'll just show these really quick. I won't go through each one for the sake of time. We've already talked about a couple: safety, trustworthiness, and transparency, empowerment, voice, and choice. But at the center of all these principles, and I think this is what's important to know about it, is this understanding of the centrality and the value of relationships. And I think bottom line, this is where trauma-informed care really shines. It kind of centers what we need to do with our patients through a frame of relationships. So in the last 5 minutes, I'll just walk through some practical opportunities for application. The first one is considering to nuance your physical exam through a trauma-informed lens. I borrowed this from a group at Brown University. You can scan the QR code there. It's a free module, very, very kind of start to finish, easy to understand, but very nice course if you want to consider some opportunities to be more trauma sensitive. But what I've done is put together some of the highlights here. So before doing the exam, I think the theme is setting the stage. And so this might include things like getting eye level, paying attention to nonverbal cues like fidgeting, tense muscles, giving an overview of what needs to be examined. So one thing you can say is, okay, I'd like to transition now to the physical exam. Since we talked about your heart problems and this new abdominal pain, I'll need to examine your heart, lungs, and abdomen by listening with the stethoscope, gently pressing on different areas of the abdomen to see if I can identify where this pain is coming from. Also, important to ask permission before you start, and then ask if there are any concerns that you should know about before doing the exam, especially on sensitive areas. During the exam, the themes are only do what needs to be done and communicate as you go. So with respect to the gown or drape, you only expose what needs to be exposed and you cover it up. Whenever we're describing what we're examining, use non-personal, simple clinical language. So and a good rule of thumb is to avoid using pronouns. So I'd like to examine your abdomen. Instead of saying that, we might say, I'd like to examine the abdomen. And I think that can really help when you're about to examine a sensitive part. So it's a little bit of a different flavor when you say, I'd like to examine the penis, as opposed to saying, I'd like to examine your penis. There's sort of a connotation there that might make someone feel uncomfortable. You can explain the purpose of exam maneuvers in real time. And then I think this last one is really helpful as well, just staying within that person's line of sight and checking in frequently. So here's some photos from this module that kind of illustrate this point of staying in sight. So on the left here, you can see that our student examiner is not within the patient's line of sight while listening to the lungs. Here, she's moved to the side where she's not in front of the patient, but kind of off to the side where the patient can still see the examiner in her peripheral vision. Here, the examiner is doing a thyroid exam, classically from behind. Instead of that, there's a thought where you can kind of move to the side and still conduct a thorough, a comprehensive thyroid examination. And then finally, this one might be a little bit more subtle to pick up on, but here the examiner is checking the radial pulse of the patient. But notice where the patient's left arm is resting. It's kind of on her proximal thigh, near a sensitive area. And so one thing that we can do if we're going to check the pulse is say, would you mind just extending your arm on your knee so that I can check your pulse? I think one concrete application of trauma-informed care is to reframe how we think about facilitating behavior change. And my argument here, or I'm pleading my case, is that we should do it in a relational context. One thing I want to challenge us to consider is to not myopically rely on the stages of change model. While this model might be helpful to organize our thinking, it tends to be misused as a label than as a guide. And then it assumes that people are linear when it comes to behavior change, which I don't know how real life that is. But one of the biggest sort of criticism that I have about the stages of change model is that there's a high risk of misinterpreting what is being said by the patient. A patient might seem like they're not ready to quit smoking, but it might not be because they don't want to quit or they don't care about their body. But from a trauma-informed view, it might be that they're just afraid that you're going to take away the thing that has been getting them through their crisis. So, and also the stages of change model is agnostic to trauma history and social supports. And so what are some more helpful scripts that we can think about? So here I have some kind of conventional things that we say when it comes to behavior change in the visit, and on the right are perhaps more helpful trauma-informed way to reframe that question. So instead of saying, are you aware of the health consequences of this behavior? We might say, how does this behavior help you? And at the risk of being misunderstood, I'm certainly not saying that any substance use problem is healthy, but what this reframing gets to is that it acknowledges that substance use can often be a coping tool, again, for people to get through their crisis. So the primary problem isn't so much the drinking, it's the thing that's making the drinking look like a good idea. And showing understanding of that primary problem, even if we can't do anything about it, can be that support a patient needs to feel like they're not alone with trying to make a change. Let me show a couple of these. So instead of why haven't you been able to stop using, what makes it hard to cut back? Or is probably a more helpful way to reframe that, as it's less shaming. Instead of let me show you what your liver looks like from your drinking, we might reframe that as, have you ever been able to quit or cut back before? So that's kind of reframing the change in the frame of past successes. Okay, so my last point is to destigmatize discussion about trauma, but I know that I'm out of time. And so I'm just going to jump to the summary here. ACEs are associated with many long-term behavioral health and behavioral problems. They're a cause of toxic stress, which can disrupt brain development. Trauma can show up in clinical encounters all the time. In some of these constructs, hypervigilance, emotional dysregulation, avoidance. We have to recognize the impact of trauma in our own lives and be willing to seek help. It begins with switching from what's wrong with you to an approach of what's happened. We talked about the 4 R's of trauma-informed care, and here's some considerations for application. And before I take questions, I'll just show the last slide here. This is a quote from Dr. Mastin, one of the leading researchers in resilience. And what I'll leave you with is this quote: "Resilience emerges not from rare or extraordinary qualities, but from the everyday magic or ordinary normative human resources in the minds, brains, and bodies of children and their families and relationships in their communities." Thank you so much for your attention, and I'd be happy to take questions. Thank you.
Thank you so much, Stan. That was really phenomenal, and made me think so much about the experiences that in our clinic at IDP all the time. It is at the 1 o'clock hour, so for those who want to drop off, we won't think less of you. Can I ask you one question? And
Sure, please.
We can maybe run over for a few minutes if others have other questions. I think you really did an amazing job at talking about how, as an individual, you can apply, some of these principles in your interaction with the patient. I try and think a lot about how do we change systems to be better as well. And, and I think there's often tension between, structure and order and in the system, and then trying to be flexible for a patient. One example that comes to mind are like late policies. The patient comes in, they're late because they just took 3 buses to get to your clinic, and you turn them away because they're 20 minutes after their time and your late policy is 15 minutes. How do you create a place that doesn't reinforce a lot of these negative feelings about the healthcare environment, but to be able to continue to keep some kind of structure or order to be able to deliver care to other patients as well?
Yeah, that's the $1 million question, Dr. Armstrong. And I think I'll answer that question kind of addressing another sort of common misperception of trauma-informed care. So, one of the sort of criticism levied on this topic is that it seems to be like an excuse. We're excusing people's behavior, right? And that's not the intent at all. I think when it comes to behavior, there's consequences for behavior and you can't avoid that. But I think there's also an opportunity for restoration that people in a position of power can seek out, right? So it's not about accepting behavior and letting that go, but it's about understanding where that behavior comes from and meeting that person where they are. And so I think when it comes to things on a policy level, clinic practices, late policies, I would say that's the approach. So if a person is really late, well, there's nothing that we can do at that moment, right? There's so many other stakeholders involved in a clinic visit where we just can't accommodate every person showing up an hour late. But I think there are other ways to sort of try to meet that person where they are. So if there's another provider, I think so it's worth the effort to say, is there another provider that we can schedule for this patient? Is there some barrier that caused you to be late today that we can help address in the future? And not every, not every approach that a clinic takes is going to look the same across clinics.
Great, thanks. I'll ask you one more question and then I think we'll wrap it up. This coming from Nate Spell. He says, what's known about whether addressing the underlying trauma history has benefit in modifying the stress response and health behavior?
Yeah, that's a great question. And not a lot, unfortunately, because, while the idea of trauma-informed care has been around for at least 20, 25 years, the sanctuary model was kind of one of the earliest models that showcased and talked about trauma-informed care. There hasn't been a lot of research that's been done on it. And so one thing that Dr. Charles Moore and I were considering at Grady was thinking about trauma-informed approaches to smoking cessation, and to acknowledge that, a lot of people, for a lot of people, nicotine is a strong and powerful anxiolytic that they have control over, right? And so if we can understand that nicotine might have a paradoxical therapeutic benefit, and we meet people where they are on that level, nobody who smokes long-term thinks that cigarettes are healthy anymore, right? The issue is not a knowledge gap. The issue is what is preventing them from sustaining their cutting back on that behavior.
Thank you so much. That's actually really a fascinating approach and thought process. There's lots of really awesome comments in the chat. There is also an interest in getting the link to the Brown study, the QR code that you had there,
Sure.
Which we could send out in some way. I have to think about
I saw Dr. Johnson post it.
He posted that med portal. Yeah.
Yeah. That's where you can find it. That's the link right there.
Okay, terrific. All right, thank you so much, Dr. Sonu. This has been really phenomenal, and I appreciate you joining us today and gracing us with your wisdom.
Thank you so much for the opportunity.